A 21-year-old unrestrained Caucasian man involved in a motor vehicle collision was ejected after multiple rollovers and was found lying on the ground. His initial vital signs in the field were stable, and he was awake and conversing. He was brought to the emergency room, ER, by ambulance at 2:30 a.m. His injuries included an open femur fracture, lower limb lacerations, and blunt chest trauma. While he was being assessed, he required 2 liters of crystalloids and 2 units packed red blood cell (PRBC) transfusion to maintain his blood pressure. The focused assessment with sonography for trauma was negative, and the first chest radiograph was unremarkable. After he was intubated in the ER for respiratory distress, a whole-body computed tomography scan was performed. This examination revealed multiple vertebral fractures, T5 to T8, and a large hemothorax on the right side for which a chest tube was placed. After draining 800 milliliters of blood, the drainage stabilized. The patient's arterial blood pressure was maintained at 120 over 75 millimeters of mercury without vasopressor support, but he was anuric. He was then brought to the ICU at 3:45 a.m. for close observation and continuous resuscitation. 1 hour later, he became hypotensive, systolic blood pressure less than 90 millimeters of mercury, and tachycardic, heart rate greater than 110 beats per minute, which coincided with the rapid drainage of 1.5 liters of frank blood from his chest tube. He was transferred to the OR for emergent thoracotomy. The source of the bleeding was the posterior mediastinum in the area of the vertebral fractures. The bleeding was still active and had breached the pleural cavity. To allow for operative access, the anesthetist placed a right bronchial blocker to deflate the right lung. Paravertebral and intercostal vessels were then controlled. Mixed respiratory and metabolic acidosis ensued. Because of intolerance to single lung ventilation, the bronchial blocker was removed on 2 occasions. After the second pullback of the bronchial blocker, the patient became difficult to ventilate with high airway pressures and low tidal volume. The patient was hypoxemic with a partial pressure of oxygen in arterial blood, PaO2, of 54 millimeters of mercury while on 100% oxygen. His central venous pressure, CVP, rose above 30 millimeters of mercury. He was paralyzed, open lung ventilation was applied, PEP equal 15 centimeters of water, ratio of inspiratory and expiratory time equaling 1, and a chest tube was placed on the left side. Due to increasing airway pressures and the high volume of fluid resuscitation administered, poor extrapulmonary compliance due to abdominal compartment syndrome was suspected. A decompressive laparotomy was performed, which led to partial improvement. The next day, the patient still met criteria for ARDS, but his oxygenation was stabilized and radiographic improvement was visible at 48 hours. In the meantime, he developed rhabdomyolysis and elevated liver enzymes and required renal replacement therapy for 13 days. He also had 2 episodes of sepsis. He was weaned from the ventilator after 41 days, transferred to the ward after 51 days, and discharged from the hospital 93 days after his injury. Prognosis: chest trauma.